Good morning, everybody, and welcome to this meeting of the Health Scrutiny Committee, which is being broadcast live. Can I accept the minutes of the last meeting, please, as a true and correct record? Everybody agreed? Thank you. And James, do we have any apologies, please?
Okay, so we have apologies from Councillor Michelle Welch for other reasons, and we have Councillor Errol Henry substituting for her. We have apologies from Councillor Maggie McGrath for other reasons, and substituted by Councillor Paul Henshaw. We have apologies from Councillor David Martin for other reasons, but there is no substitute. We have apologies from Councillor Mike Adams on other county council business, who is being substituted by Councillor Reg Adair. We have apologies from Councillor Steve Carr for medical reasons, no substitute, and apologies from Councillor Doddy, no substitute.
Chairman, I'm overly new to this council. I've only been here for 4 years. But isn't the protocol that we're supposed to say what the other reasons are, not just say other reasons? That's what I was always advised.
It is actually just the other reasons. We don't go into that level of detail.
Yeah, I think that's just a normal thing. John. Thank you, members. Thank you. Do any members present have a disclosable pecuniary interest to declare, please? Or do members present have a private interest, pecuniary or non-pecuniary, to declare? Please do so. Bethan?
Just say that I'm appointed governor at Nottinghamshire Healthcare Trust and vice chair of the Nottinghamshire ICP.
Yes, just that my daughter works for the NHS. It's only
okay. Bless you.
Just in case anybody who wants to be funny about things.
Thank you. Right, we'll move on to item 4, Nottinghamshire Healthcare NHS Foundation Trust Rampton Improvements Update. The next item for consideration is an update on the Healthcare Trust, which was requested at the October meeting. Members will have received a copy of the update report circulated late last week. I hope you've had a chance to read through it, and also there was an amendment come through as well, so I hope you all had a chance to read through that as well. And I would now like to welcome representatives of the Healthcare Trust, Jan Sensier and Chief Director Partnership and Strategy, and Diane Hall, Chief Nurse, to today's meeting. Welcome, ladies. And can I invite Jan and Diane to present their report, please?
Thank you. Before I hand over to Jan, who's going to present the report, we'd like to apologise for putting in some information, although we did identify that it was a draft report from the CQC. We cannot make any comment on any draft report. It is going through factual accuracy, and that's why we put the amendment in. But we apologise for any confusion or any concerns caused. But I wanted to be upfront with that right from the beginning. And I would like you to know that I have spoken to CQC and been really open, transparent about what's happened, and that's all okay.
Sorry, wrong button. Thank you very much. And as the chair has said, I'm Jan Sensier and I'm the Exec Director of Partnerships and Strategy. I have overall responsibility for coordinating our improvement plan. Members will remember that we came to see you in October, and we then at that point went through the background to why Nottinghamshire Healthcare Trust has an overall integrated improvement plan, the background to the Section 48 special review that was conducted March of last year, the recommendations from that, and also the fact that we are now in something called National Oversight Framework Segment 4 of the NHS Oversight Framework, which in effect, I guess it could be called a special measures. And as a result of that, we have been given some transition criteria to meet, and we are expected to meet those transition criteria by March 2026. And when we discussed last time the overall report, members were interested in having more detailed examination of a couple of areas of that improvement plan. One of which was Rampton. As you'll be aware, Nottinghamshire Healthcare Trust is responsible for running services at Rampton High Secure Hospital. Just a little bit of background for Rampton. I know some of you are very familiar. Obviously, Rampton sits within the Nottinghamshire County Council area. It is one of 3 high secure hospitals in England. There's one in the south, one in the north, and Rampton serves the Midlands. It has regional services, so it takes patients from across the whole of the Midlands region. But it also has a number of national services. It is the only high secure hospital for deaf patients, for female patients, and for patients with learning disability. So it is a very highly specialised hospital, and around about 300 patients overall are at Rampton. Clearly, being very highly specialised, services are extremely important at Rampton, and we know that there has been a history in the last few years of CQC visiting our services and finding them inadequate. And in January of last year, they had an inspection report which they published, which said that Rampton was inadequate. So when the Secretary of State then ordered the Section 48 special review, alongside looking at our community mental health services, the then Secretary of State, Victoria Atkins, also asked for that Section 48 to look at Rampton. The CQC report that was published in January 24 was based on an inspection that took place in July and August, sorry, yes, I think it's June and July actually, of 2023. And since between the visit and the publication of the report, we had noted a number of improvements that had already been made. So when the Secretary of State commissioned the Section 48 review, she asked the CQC to identify whether there had been those improvements, whether they were evidenced, and whether they were sustained. And what came out from the CQC Section 48 review was an overall opinion that yes, they had seen some improvements, and that those improvements did look to be sustained, but that there was more to do. And in the report, you will see the recommendations that were put in that report of what we needed to do to improve still further. The appendix to the report does go through each of those recommendations and where we have got to in addressing those recommendations, and I can say a little bit more about that in a moment. Alongside that, I also mentioned the National Oversight Framework Segment 4, which has these transition criteria. There are 7 of them overall, and one of them specifically is about being able to evidence that we have that sustained improvement at Rampton Hospital. So I think this is why members were very interested in finding out what we have been doing since in the last year now to continue that improvement. You will see that the recommendations that came from the Section 48 report were a mixture of the how we actually learn and develop our services and support our staff to improve services, how we have a culture. We have nearly 2,000 staff working at Rampton, so the culture is incredibly important. It's really important that we support those staff to do the best job that they can for our patients, but also some very specific recommendations that were there designed to improve our care of our patients. I'll start with those specific recommendations. I mentioned that we have the only national deaf service high secure for high secure patients, and what the CQC had found was that whilst we had trained a number of staff in British Sign Language, it wasn't consistent enough, and we didn't have sufficient staff trained to a high enough level of British Sign Language, and at times, particularly over evenings and nights and weekends, we didn't have sufficient staff in place. And if you can imagine, if you're at Rampton, you are suffering from a severe mental illness, and if you can imagine the communication difficulties you already suffer if you have a severe mental illness, and compounding that by the fact that you're unable to use a language that you can get other people to understand you in. We know this is a very serious issue, and that we needed to address it. I'm delighted to say that we have actually now got the ward is full of staff now that have got both level 2 and some level 3 British Sign Language trained staff. And I'll just give a little example. I recently met the housekeeper on that ward, and she has trained in British Sign Language, and it makes such a difference because housekeepers will interact with patients alongside everybody else. So as well as the nursing staff, we are training all staff that work with those patients in British Sign Language. And we do have something called Care Opinion, and patients at Rampton are able to access that and to put their comments on Care Opinion. And the patients from that ward in particular have been very active in both highlighting where they think we need to do more, but also in praising the work that we've done. So we are seeing some real benefits from having increased the training around British Sign Language, and what a difference that's making to those patients and their care. We also have been criticised for deploying, because of staff shortages, deploying the staff that we have to do therapy and education for patients, deploying them into sort of the general nursing care shifts on the ward because of short staffing. And we were asked by the CQC to stop doing that and to make sure that patients were getting the meaningful activities that they need. They're expected to get around 25 hours of meaningful activities per week. And I'm delighted to say that we have been able to stop using those therapy and education staff. It doesn't mean that we never ever have to do that deployment. We all know what it's like when you're running a large organisation. Even yesterday, we had some problems because you'll be aware of the flooding around Rampton, and so some staff were unable to get in. So there will always be emergency situations, but it stopped being a routine redeployment, and now that means that the meaningful activities for patients have increased, and they are able to have those very important therapeutic engagement opportunities. You'll also see that the recommendations included working more closely with the other two high secure hospitals to learn from them, and I think that's been a real benefit of the last year. We have developed very close working relationships with both Broadmoor and Ashworth, and they have very kindly lent their expertise. They've given lots of time, and we now have got a group of 3 hospitals really working well together, and actually they're learning from us as well. So there's a really good interaction between the 3 hospitals. Just an example of that is that our Chief Digital Information Officer, which relates to one of the other recommendations around our IT equipment, is now in a group with the other 2, with her counterparts from the other 2 high secure hospitals, and they're working together around what is the digital offer that we can make in a high secure environment where you have to be incredibly careful around the security of digital products. So I won't go into all of the recommendations. You've got the appendix and you can see the things that we have been doing. I'm going to invite Di in a minute to just say anything further about the work, but I think it's really important to talk about how we're supporting staff, because as I say, the staff are there day in, day out. This is a very intense environment to work in, whether you're a nurse, whether you're a doctor, but also whether, as I've mentioned before, you're a housekeeper or whether you're a support member of staff, a therapy and education psychologist. It's a very intense environment. And so it's really important that we get the culture right. And we are doing a lot of work on the culture. We're investing a lot of time and skills training, but also in helping, for instance, the ward managers to work together and to support each other. And I think that's really paying benefits. But I'll ask Di to add anything further.
Thank you, Jan. Well, the report identifies or details a number of things that we had to do, but I want to assure you that the overarching aim was really and truly about improving patient experience, because we know that that's what's really important. A couple of other things to add. One of the other concerns was around clinical leadership, and as Jan has said, there is so much clinical expertise required. within a high secure hospital. We have appointed a dedicated care group nurse director. We've appointed a associate medical director specifically for Rampton Hospital. And we have appointed 4 clinical directors as well. So we are moving very swiftly towards clinically led, operationally delivered services, which is really, really important for Rampton. One other thing about the National Deaf Unit is, as Janice explained, we have increased the number of qualified BSL staff, but we've also employed a number of staff who use BSL themselves. And talking to those patients before Christmas, when I went over to play bingo with them for their Christmas party, it was wonderful to hear them talk about being able to engage and relate to people who looked like them, talked like them, and were like them. And that kind of fits in with our overarching focus on relational security. And by that I mean our relationships, our engagement, which really make risk management and promote safety. But I think Jan's covered everything else.
Okay, thank you, Jan and Diane, for that report. I'm pleased to see that you are taking notice of the CQC recommendations, and you are sort of trying to improve the benefit of the patients and the. I mean, the definition of it, is it a hospital? Is it a prison? Or is it one of these? Which is something that I've been asked actually. What exactly at Rampton is?
It is a hospital.
It is
And
actually
it's a hospital, and it's an NHS run hospital.
right. Okay. So are there criminals inside there?
So some of the people will have committed offences, and some very serious offences, but we also do have people who have escalated into Rampton through mental health services. So it has been their behaviour in mental health and the severity of their illness within mental health facilities that have they've gone into one facility, we've not been able to contain their behaviour and their illness, and they've escalated into Rampton. So not everybody in Rampton has committed an offence, a criminal offence, in the external world.
But some have, yeah. And what percentage? You say you specialise in female and deaf patients. What percentage are deaf, and what percentage are female there?
There's one deaf ward out of 18 wards, is it? 22 wards in Rampton.
And the women's is 2 wards, so not a high proportion.
Not a high proportion.
But a group of people who need really careful and compassionate and expert care because of the way that the symptoms from their illness are exhibited and the levels of distress associated with that.
Okay, thank you. Right, I'll open it up to members. Sorry. Councillor Henry.
Yes, thanks very much, and Chair, thank you very much for your sort of explanation of what's the reason why we got the second bit of the report, which is useful, and thank you very much for both of you for explaining it away. I've got some questions on page 18, 19, and 23. On page 18, a bit in the summary progress table. Just 2 questions on that. Could you just explain why there are so many NAs in there? Do they represent bad news that you are reluctant to share with us today? Or were those elements not featured in the proposals for improvement? If so, how can the effectiveness of treatment at Rampton be non-applicable?
I think you're referring to the first report, the one that was then withdrawn.
Oh, it's withdrawn. Okay,
and put in. And just to let you know that the NA just meant that the CQC hadn't inspected those areas.
Okay.
But as we've said, we withdrew that report because the CQC have not finalised their report yet.
Right.
May I add to that? Just the CQC are carrying out very different kind of inspection. So before they used to come and inspect every bit of the key lines of inquiry. Now they use something called the single assessment framework. So they have a number of quality statements against each key line of inquiry, and they have to complete a proportion of them before they can rate. So often they'll come and do two key lines of inquiry, but they won't have done the other three. So that's why the report would have looked like that.
Just thought I'd ask. And the question on the same page 18, is about Rampton's women's services effectiveness says good. What does that mean in terms of tangible results? Are you seeing successful treatments and higher, faster levels of discharge?
So again, that's referring to a report that we've withdrawn because of the CQC ratings. But I think in terms of what I'm going to ask Di to just talk about what the things are that the CQC are looking for in those quality standards. But it is very much based around the patient experience and safety. But I'll ask.
So that would be things around the effectiveness of the care plan, the treatment plan, the interventions, medicines management, use of any restrictive interventions. It would be about the overall care.
Okay. And Chair, and I move on to page 19, the bullet points, I think seven bullet point there. It talks about pre-COVID levels of patient admissions. Could you go into more detail on the changes at Rampton since COVID and how staff have or haven't been able to safely care for patients?
Yes, I mean, I think what the sentence that you're referring to is the fact that what happened was that when we had the inadequate reports, the CQC limited admissions to Rampton. They said that we were not ready to be able to admit the normal level of people that we would normally admit. What they have now said is that we are able to get back to those normal levels of admissions. So when it says pre-COVID levels, that really means that we're now, because these patients are highly, highly complex patients, and you do not get the turnover that you would get even in lower security hospitals or in other mental health hospitals. And so each admission takes an enormous amount of work to get that person in and settled with a care plan and a risk assessment and all of those things. And the CQC were nervous at one point about our ability to take on that level of admissions. They're now back to the pre-COVID levels, so that shows a sense of the CQC have now got confidence that we're able to cope with those levels of admissions again, and that's what the pre-COVID stands it relates to.
Yeah, and finally, Chair, on page 23, appendix 3, it refers to the 75 nurses plus 30 more soon, the recruitment of those nurses. Is it sufficient to provide safe staffing levels? And could you also outline what your staff retention rates are like?
I can start. I don't have the retention levels Jan might. We have been successful in appointing a number of new nurses, and we've also, as in the report, we've carried out an establishment review, and that was an establishment review of nursing. So we used something called the MHOS tool, which is a national tool to look at safety and safety on wards. And our buddy trusts, Ashworth and Broadmoor, helped us with that establishment review. And we agreed, and it went through the Finance Committee and Board, that we would increase our establishment so that we could ensure safety. That amount of qualified nurses means that we have very, very few qualified nurse vacancies now. We have healthcare support worker posts that we're appointing into. We seem to attract large numbers of healthcare support workers, so we aren't envisaging any difficulties in meeting those new establishment numbers. In fact, we're really confident about that, and we are able to have safer staffing on our wards currently.
I'm afraid I don't have the retention rate specifically for Rampton to hand. What I can say is that Notts Healthcare retention rate has significantly improved over the last 2 to 3 years, and I think our overall retention rate, I think our turnover rate now stands at something like 13%. But what we can do is we can pass that information to the committee and make sure you've got that to hand.
Thank you very much, Chairman. I just want to preface this to say, although I'm going to ask a few questions that may seem a bit provocative, do know it's with the best intention of being that critical friend. We are just laymen, after all. So, first question: Recommendation 4, in terms of process, the recommendation is putting place a dedicated team essentially. In your bit of complete, I don't think there's any particular mention about a team being set up. Obviously, you've gone through the new processes, but there's no mention of a team. I'm just wanting to ask: is that being done? If you've gone through this process, has that been with consultation of your other organisations, of your other hospitals that you're partnering with, and they're saying that's okay?
Yeah, I can say something about that. So the dedicated team was to do the review, and we did have a dedicated team to do the review, and that review was done with Broadmoor Hospital, and they brought some really significant expertise into that. So what the review did was to set up that new process, the new digital process. They used their expertise to advise us on how to set that up and to put that in place. So the dedicated team wasn't a long-standing dedicated team. It was in order to do that review, which we've now completed, and we've put in place the recommendations from that review.
Great, that's good to hear. Recommendation 5, it mentions you've stopped using therapy. You mentioned in your talk about how you stopped using it as a routine. I suppose my worry is that I don't think it was ever a routine beforehand. Before the CQC came in, they kind of pinned it and said, you're doing it a bit too often. I know you mentioned about floods, for example, where you've redeployed them. How often are you having these emergencies in the past, let's say, 3 months, essentially? I don't know. And do you want to answer that now? Or?
So that would only be in emergency situations. As you say, the flood was one of them. The only other situation would be if we have a number of patients who are out of grounds, because as you're aware, we'd have to have a number of escorts go out with them, and that's if they need to go to an acute hospital. However, that doesn't stop activities and groups happening on the wards. So when we think about the TES, the therapy and education, that is structured groups, usually outside of the wards. What we have been doing and what we've been documenting is the activities we've been used to compensate them. So this would be, it isn't custom and practice to use TES staff to cover gaps in our staffing. Not at all.
I think it's true to say you're right that it wasn't routine, but it had become too common, and that's what the CQC picked up on. It had become, if you like, what was happening was the first line of call when there was a staffing problem was to bring in the therapy and education staff. We've now made it the last line of call, and I think that's the real difference.
Yeah, I suppose we'll just have to wait and see on that one to see what CQC pick up on essentially when it comes.
We
so
will.
Hopefully it's good news.
Hopefully so. One of the things that we do though is we monitor now weekly whether every patient is getting their 25 hours of meaningful activities, because that had dropped off, and we are now making sure that we're monitoring that on a weekly basis.
And my final point about the recommendations is regarding the IT equipment. Now, if Councillor Adams was here, he'd probably have a lot more to say about it. But I suppose my concern actually is the last sentence where it says you've adopted IT devices to avoid staff having to log in multiple times when they're in use. Now, my first protocol is, GDPR. What's the risk associated with that? Is that something the partner organisations have said is okay? Or?
Yes, it is. And actually, I think it's fair to say, and this probably, I'm responsible for digital in Notts Healthcare, so I can probably say this, we've probably erred on the side of caution, probably a bit too much in the past. So one thing I'm very confident about is that we have really good IT security, really good cyber security, and good GDPR compliance. And we'd probably gone a bit over the top. And staff, we've now been able to safely get to a point where staff are not having to log in so many times. I think it's also fair to say that we're actually, and I know Broadmoor and Ashworth are particularly interested in some of the IT developments that we've done at Rampton, one of which is something that's called Made Purple. And that is a system which allows patients to safely access certain parts of the internet in order to be able to develop their skills, because obviously our ultimate aim is that they'll be discharged into the community. And as we all know now, IT is very much part and parcel of our daily lives. And so we are using that Made Purple, which is very safe and makes sure that that, you know, it's restricted access, but it does allow them to learn the skills about how to access the community, which is why patients can get onto the care opinion and put their comments about their care onto care opinion.
Okay. And final question is, I know in the bullet points, we're moving back up here to page 3 of your report, had a few quotes from family carers and patients. I know we've almost touched on, you know, patients feeling that the death service is actually a lot better now. I suppose my question is, because we only get these reports, we don't see the negative criticism coming from patients or families. Has that reduced, or can you provide an example where someone has been critical of your service in recent times and you've actually taken that aim to actually improve it? Because obviously, if it's not working for families or patients, you know, it's great having the positive news, but you know, I know there's probably a complaint in there somewhere.
Oh, there are complaints, and actually Diane and I, we sign off all the complaints that come through the trust, so we see those complaints. They are not. There are not multiple complaints from Rampton in the way that I think at one point we did have. I think I would also really urge counsellors to look at care opinion. It's very easily accessible, and if you go onto care opinion and if you search by Notts Healthcare and Rampton Hospital, you will see the multiple comments that patients put on about their care. But what you'll also see is that, and I'm really pleased about this, is that our staff get onto it quickly and respond to those complaints, those concerns, or even if people have put praise on there, you'll see that staff respond very quickly to what's posted on care opinion. So yes, you're right in terms of you know, that there will be people that say negative things. And I can think of one patient in particular who recently complained about part of their care, but actually when it was explained to them how that care was delivered and why that care was delivered in order to keep them safe, I think they did understand that. And I think a lot of this comes back to that relational security that Di was talking about, the ability to really be able to develop those meaningful relationships with patients and communicate with them and help them to understand. I think in the women's service in particular, the levels of self-harm can be extreme, and sometimes nursing staff have to take measures to try and help people not to harm themselves, and then understanding why they've taken those measures is a really key part of that interaction with patients.
Yes, just to add, I mean, we're not going to sit here and say that everybody gives compliments about the service, because they don't. You know, we are improving, but we're not fully improved, and we're really honest about that. As Janice touched on, when you're taking away people's liberties, when you're having to at times restrict use restrictive practices, then there will be concerns. But what we've been focusing on is how do we debrief with patients after we've had to do an intervention that might be restrictive? How do we explain why we did that, and also explore how it felt and how maybe things could be handled differently next time. So we're really focusing on that debrief part. Equally, we're focusing on the learning, not just learning from incidents, but learning from complaints and learning from concerns, and seeing those complaints as an opportunity to improve. But there are people who still have concerns, and we have to be honest about that.
Absolutely.
Thank you, Councillor Bailey. Could you go back on one point that you made about IT? You know, it's great to see the security and that's improved, but you mentioned Ashford and Broadmoor there. Are the actual computer programs that you use, are they compatible with those two other places? So you can actually integrate your system into theirs if need be, or is it completely separate? Or if you need to talk to them about things, you know, are you compatible in any way?
No, each NHS trust has its own IT system. There isn't a standard system across the NHS. But what we are able to do is to learn from each other. So, for instance, we have a system for recording those meaningful activities that we talked about earlier, and that's something that we have. We work together with Broadmoor and Ashworth to understand how we can use those systems in each other's trusts. They might be on different platforms, but they're compatible in the sense that we're learning from what works and what doesn't work. But no, that there isn't that interaction in the way that you've described. We do not have one single NHS system that allows that to happen.
I'm personally consider that a disadvantage actually, but anyway. Councillor Anderson.
Thank you, Chair. So you've highlighted your commitment to the BSL provision for patients that are deaf at Rampton. So in regard to patients with complex learning disabilities, are other communication methods used, such as Makaton perhaps, things like visual timetables used? Having worked with children, obviously children, not adults, with additional needs, I know how important routine is for people. So I just wondered, are all the patients with complex needs at Rampton catered for, and what sort of things do you offer them? Thank you.
Yeah, thank you. So within our learning disability services, we have a number of learning disability nurses and people with the expertise. We look at the reasonable adjustments that we need to make. We do use visual signing. We do use a range of different interventions, but it's particularly about those reasonable adjustments and the importance of routine and structure for some people. The other important thing for us is contact with families and contact with people who really know them well. But we have a range of interventions within each of those units. So if you take women with complex needs, we will have DBT inspired interventions. We will have CBT inspired interventions as well, but we will also spend a lot of time around distress tolerance and distress de-escalation as well. So as Jan said right at the very beginning, because of the kind of expert nature of Rampton, we have people trained in all of those interventions. We also have 3 nurse consultants, one of them who specialises in psychological interventions. We also have a very big psychology department, so that we are psychology informed as well as kind of providing psychology-led interventions. I think that's really important, because you need that multidisciplinary team approach, and you need the range of approaches as opposed to just a pure medical model. And again, the focus is on relational security, and that is very much around being creative and inventive in the way that you engage with people. But also, in Rampton, those care plans are really, really patient focused. They are written with patients, they are owned by patients, and they are shared with patients. And I think that is really, really important as well. And we are seeing that through Made Purple and Care Opinions.
And just to add to that, because you mentioned communication tools, I was really struck. Our learning disability consultant runs an annual conference for working with learning disability patients in a secure environment, and I was privileged to go to that conference this year. And I would say over half the speakers were speech and language therapists, talking about how they have tried different communication methods for patients with learning disability in a secure environment. And there was so much learning going on in that room. And we have a number of very specialist, very highly specialist speech and language therapists at Rampton working with our learning disability patients, using a whole range of different communication methodologies and helping the staff as well to understand how to deploy those communication methodologies.
Thank you. Thanks for coming. It's almost 50 years ago since I had any connection to Rampton. I used to chaperone patients as an ex-policeman. Long time ago. So I wouldn't say it was close to my heart, but from the information you've provided today, there's a 7-to-1 ratio of staff to patients, which I suspect is quite financially is quite difficult. Does that impact on the rest of the county NHS services?
No, it doesn't, because we are commissioned to provide services at Rampton by National NHS England. Right. So it's a completely separate pot that funds Rampton.
You talked about care plans and risk assessments, etc. How often are they reviewed?
So the standard for reviewing care plans is monthly. Risk assessments should be reviewed in every ward review. So you'd be looking at particularly when you're working with people with complexity. So looking, has risk increased? Has it decreased? So it's not so much a standard time frame. It would be more around, it being constant updating of risk, particularly in an environment where risk and safety are critical, as you will know from being there.
So the staff, you'd have a regular staff working on a particular unit, particular ward, etc. They would know the patients, etc.
Absolutely, and then you'd have a consultant and a multidisciplinary team, and there would be those regular ward reviews as well. And then obviously you've got your safety huddles, and you've got your nursing forums, and you've got your community meetings, and you've got your individual one-to-ones, all the time thinking about risk, interventions, are they working, do we need to do something differently within the context of a secure environment.
Thank you.
Thank you very much. Sarah, I think you want to ask that, and welcome to the meeting, Sarah.
Thank you, Chair, and great to see you this morning. There's loads I could ask you about the deaf ward. It's something I've worked extensively with deaf community on a number of health issues, and at Health Watch we've picked up a few issues within the trust which aren't necessarily at Rampton but in other areas. You mentioned obviously you've got BSL trained staff. I'm just curious as to how, as the only national deaf ward that you've got in a secure unit, how the deaf community is engaging with you around that service. In terms of my experience and understanding is that the deaf community is vastly underserved by everybody, and having the only deaf unit in your hospital, it's no surprise to me that it's now that you're starting to think differently a bit about the level of staffing and how you use staff. It's commonplace, I think, in terms of the underserved population. So I'm just interested in terms of what external support you're getting from deaf organisations nationally to support your cultural understanding of that community, the language understanding, the use of IT. There's a whole raft of things, and I would probably love to have a further conversation with you offline. But I think for purposes of scrutiny, and that this is one of the only few areas of the CQC report that you're still working on, I'm just interested to understand how you're engaging with deaf people and deaf organisations to make sure that you've got the right services in that particular service.
Thank you, Sarah. I don't think I can give you a very complete answer because I don't have that detail to hand. I know that we do have some connections. I think there's always more we can do. As Di said, one of the big improvements over the last year, and I've met them, has been the introduction of staff who are deaf themselves, who use BSL as their main method of communication. That has made such a difference on that ward, because it's all very well as a hearing person to learn BSL, isn't it? But to actually have people working alongside you. And your point about community is such an important one. I met a recent patient who'd come onto that ward, and he'd come from prison. And I said, how do you find this? And he said, I feel like I've come home, because he hadn't been in a specialist service in prison. And he felt for the first time that he was in a community that understood him. So I fully appreciate what you're saying. We use some very specialist interpreters as well at Rampton, who come from deaf organisations, and we do have links, but I don't have the detail. What I'd love to do, Sarah, is to invite you to come and visit that ward, because I think you've got that specialist knowledge and interest, and I think it'd be great if you could come and visit the ward and talk with the staff about and give us some help in terms of developing better links as well. Thank you.
Thanks, Sarah. Councillor Lee.
Chairman, thank you. It's really difficult to hear that Rampton has been put in special measures. We only heard at the last meeting that sadly a tragedy in Nottingham was led due to not having the mental health facilities in place, and we're now being advised that the place where these people would go is also failing. It's very, very difficult to hear. My questions are, could you explain the differences in service for people? The first question is, could you explain the sorts of criminals, and if I don't use the right terminology, I apologise, the sorts of criminals and what convictions they would have that would go into Rampton first, please?
So I'll start by just explaining a little bit about your introduction. So the Section 48 that we came to talk to you about last time was partly as a result of the inadequate report that we'd had from CQ. So this is not new. This was from January last year, and it's all part of that special measures. It was one of the reasons why we were put as a whole into National Oversight Framework 4. So it's just to give that nuance to that. In terms of the offences that the patients will have committed, and as I said, not every patient at Rampton has committed an offence. There are some very serious violent offenders in Rampton. People who have committed very serious crimes in the outside world, and you've already heard me explain that we have patients who come to us from prison, where they have been in prison and then they've been identified as actually having a very severe mental illness, and their level of security means that they come to Rampton. We have other patients who have come through the mental health services and arrived at Rampton. I don't know, Di, if you want to say anything further.
I think it's very difficult to sit here and list, lots and lots of crimes, but high secure hospitals, as Jan has said, are for people who have committed a crime, who either at the time of the crime or later in prison have a serious mental illness. It's also based on the risk and the safety, but there is a large proportion of people in there who have committed no crime, but are there because of how their illness is demonstrated by risk behaviours. I do think it is really important to note that this is the whole organisation in NOF4, and that there has been significant improvements in Rampton Hospital. Equally, those concerns, as you can see, were not about the overarching safety of Rampton Hospital. They were about specific things and specific interventions. But again, there has been improvements, and I hope that next time we come back we can share a number of things from the CQC which will be able to demonstrate that without it being just words.
That's kind of the point that I'm getting to. I wasn't aware, and I'm sure our residents would not be aware, that we have people that haven't committed an offence, that haven't got convictions, that are being kept with people that have got convictions. If somebody was to murder my child and get sent to prison, I wouldn't want them being treated in the same level of somebody that hasn't been convicted, somebody that hasn't been. When they get sent to prison, I want them to have their rights taken away from them and them to be kept away from people. I don't want to be hearing that they're being treated any differently to if they were in normal prison. Yes, we want to keep them safe and we want to look after them, but when they go to prison, they should have their rights taken away from them. And that's what I want to hear from you. That even if, well, let them say that. I want to know that if somebody was to murder somebody and was to be in normal prison or be in Rampton, they would be treated the same. They would have extra care, but they would be treated the same. What I am hearing, and I hope I'm wrong, is that people that haven't committed an offence are treated the same. Well, they won't have their rights taken away from them. They won't have be treated in the way you would expect somebody that has killed somebody, I would hope. So that's what I'm trying to get down to here today from hearing what's.
Councillor Lee, if I may, can I just remind you at the very beginning of the conversation, Rampton is not a prison, it is a hospital. And it is a hospital that treats people with serious mental illness where there might be risk behaviours as well. But it is a hospital, one of 3 high secure hospitals. People who have not committed any crime, who are in there, it is because of the level of risk behaviours demonstrated, where It isn't. It's because they cannot be cared for safely in any other environment. So that is about safety and risk. But I really have to repeat, and I think it's really important. It's Rampton Hospital, not prison.
And if I could just add that we work totally in accordance with the Mental Health Act. So everybody that is at Rampton will be detained at Rampton, because people are detained at Rampton through the Mental Health Act, and we work with national colleagues to make sure that when we have an admission, that is done in accordance with the Mental Health Act.
And that's kind of the point I'm making. It isn't a prison. You said your own words that somebody that came to you that from prison felt like he was home. Yeah, I'm not surprised he felt like he was home. He just got out of prison. And that's the point, is this system is, well, you can shake your head. This system isn't working. When we send people to prison, we want them to be cared in prison. And what I am hearing is that they are being taken out of prison and being cared for with people that haven't been convicted. That is wrong, in my opinion. And I'm sure the residents will have their views as well.
Thank you, Councillor Lee. I think we have to recognise this is a specialised hospital for specialised people with special needs, and not everybody can go through the penal system as we think they should do. There are different cases to adhere to. Councillor Eddie, please.
I'm not sure I can follow that. I'm going to bring it back to reality, and I think when you said about people coming home, it was because they were coming back to a community of people that were like them. So I'm going to try and follow it. Loads of work's been done, you can see that, and there's still lots more to do. I suppose my question is around the culture and staffing and how staff feel, because obviously they've been under the microscope now for a long time. How are the staff? How are they feeling? And is there more that can be done to help them?
Thank you, and that's a really good question. There's always more that can be done, but we are really working on those relationships with staff, and I'm the exec lead, and Jan is always in Rampton as well. So it's important that we're having regular conversations with staff, and that we're hearing the good, the bad, and the ugly. We've got a number of development programs in train. We've got work that we're doing with our clinical leaders. But the reason why we've introduced those new roles is so that people can spend time on those wards, not just during 9 to 5, out of hours and at night, really hearing what it's like to work in Rampton. And yes, there is some more work to do, but we have seen an improvement in the culture. And I think that also is evidenced by the improvement in the experience of patients. There is some really, really good work that happens at Rampton, but we also know that it can be a very challenging and very complex environment, and that's why we've put in increased supervision and support, because that's really important, isn't it, to feel psychologically safe and to make sense of the work that you're doing. But it continues, but it's kind of up there, kind of number one really on our improvement plan.
And just to add, because we've got more recruitment, as Sai has already explained, ongoing, one of the things that we're doing is really ensuring that as we recruit to values, because it's so important to get people who've got the approach that is going to work in that environment, because it's not an easy environment to work in, and it's really important that people have got that patient care really at the heart of what they do. We know that Rampton is a very important employer for that area. You know, it's not an area of lots of industry, is it? So it's a really important employer for the area, and we're really aware of that. And so it's really important that we invest in staff.
Councillor Dare, please.
Which one? I was wondering which one to use. I'm just a bit puzzled about. You said there's Broadmoor, there's Ashworth, and there's Rampton, and then in scrutiny conversations, you don't seem to share best practice. You don't seem to work together. Yet you're all NHS. And why is the segregation? I would have thought you'd be sharing best practice. You'd be looking at sharing experiences, and like IT, you've got 3 different systems. That doesn't sound to me good economics or good business. for best value or anything that you're trying to do. And I just find all of that really about complex and sort of we're our own little hub and we don't do things, yet we're sharing an environment that is global by being 3 institutions in the country. I just don't get it. And is there a reason for that? Is there a self-interest for that? Or is that the way that the NHS works?
Thank you, and I'll let Jan come in around IT. I think it would be fair to say that 2 years ago we weren't sharing best practice and we were working in isolation, but we're not now. So we are working together, we are meeting regularly, we are sharing best practice, we're having mutual support and supervision. People from Broadmoor come to our rapid improvement groups. They have mutual support for ward managers. There's a real clear, high secure clinical network in place. But I'll let you speak about data.
Yeah, and just to add to that, people from Ashworth are the people that are actually working with us to develop that cultural improvement programme that we discussed before, because they've done some really good work up in Merseycare. So I think you're on IT. This goes broader than Rampton. The NHS has not got a single IT system. And so each trust is responsible for having its own digital system. There are a number of suppliers that supply that are known suppliers that have developed products that are very popular amongst either mental health trusts or community trusts or acute trusts, and we use one of those in Rampton as our main system. But each one is tailored to the trust that runs it. Now, absolutely, you could argue that, wouldn't it be great if the NHS all had one super duper system that we all worked to? But that isn't the way the NHS works. We're all responsible for our own IT. What we can do, though, is we can learn lessons from each other. We can understand what works well. We can develop programs together, and that's what we are now doing. As Di said, we didn't do that before in the digital world. But our chief digital information officers are now, between the 3 hospitals, are now meeting very regularly. They're working together and they are making sure that they are developing, when they can learn from each other about the systems that they develop.
You just get back to this, and I mean, you hear every day of the week that the NHS is short of money, the NHS is short of this, the NHS is short of that. Yeah. Where you could be sharing experiences, saving costs, saving this, having one system. Everybody's a guinea pig instead of one guinea pig and setting it all up and sharing it about. I mean, I just find it.
Well, we are. I think that point about guinea pigs, that is what we are much better at now. So we are trying something out in Broadmoor and then working on how we can use it in Ashworth and Rampton. And so it will be that we'll be able to share things, but we would just have a different platform to put it on. But we are sharing. We are absolutely sharing. And the issue about, the way that the NHS is set up in digital terms is beyond the remit of Notts Healthcare. We're not able to do anything about that. But what we can do and what we are doing is absolutely doing that thing that you were talking about in terms of guinea pigging it, trialing it somewhere, learning from that, building on what each other's doing.
Yeah, I think there's a lot of room for improvement in that direction, admin-wise, and that money then could be spent on patients.
Yes, it is a quick one, Chair. Thank you. Obviously, you're a national hospital, so you're here at Scrutiny. You're based in Retford. I'm just curious as to where else you are scrutinised for services that maybe other local authority health scrutiny. I don't know if you visit others, because obviously being such a specialist hospital, I'm just interested in how your Rampton itself is held to account across the country.
So I mentioned before that NHS England are responsible for commissioning the service. So they are responsible for scrutinising how we deliver that service. There is something called a national oversight group, and that that group has not just got NHS England on it, but it also has some independent experts. It's independently chaired, and we have to account to that group on a quarterly basis, is it, Di? And we have to give them a lot of information. That's where the performance oversight comes, and also they visit regularly. And they come and visit and see what they see on the walls. So there's a lot of scrutiny that comes through that national oversight group. And then obviously we've got the CQC that we've already mentioned. And as Di has explained, the way that the CQC are now operating means that there isn't a month goes by without us having a CQC visit at Rampton of one sort or another. So it isn't that local authority scrutiny that you've talked about. Obviously the other high secure hospitals go to their own local authorities, but there's a big national infrastructure of scrutiny that we do report to. The other thing that I should say in terms of our overall improvement plan is that we are answerable to the Oversight and Assurance Group, which has been set up jointly between NHS England and the Integrated Care Board. It's jointly chaired by Amanda Sullivan and Jess Sokolov, who's the Medical Director of NHS England Regional Team. And actually, Notts County Council do have a seat on that board, as do Health Watch. And we report all of our improvements through to that group that meets monthly.
Just for information, Chair, as well, just to know that Health Watch has done interim review at Rampton in the past. It's something that we have the power to do that, and I know when we have done that and looked at patient experience at Rampton, it's been used by the CQC to support their investigations like we are doing currently. So obviously that's something we may be able to work with you on, particularly around the deaf ward. I've got some ideas on how we can do interim review.
We'd really welcome that, Sarah. Thank you.
Thank you very much. I think that's pretty... Oh, Councillor Wilmot, sorry.
Thank you, Chairman, and thank you all for your report. Very, what should we say, incredible, really. And I am pleased that the crisis at Rampton Hospital will continue to be kept under scrutiny. But we haven't identified that there's clearly been some big help and support to the hospital in trying to alleviate some of the problems. And as I say, it's clearly made a big improvement since the deaths of Barnaby, Webber, Grace O'Malley, Cumore, and the former Morwell School caretaker Ian Coates in Nottingham in June 2023. I certainly welcome the new buddying arrangements. I really do, with the high security hospitals, as well as with Northampton Trust and the National Recovery Support Programme, as a number of experts in the field will be working together. And that's the whole thing. Partnerships are the in thing, and until you get that right, you know, improvements won't appear as much as they should do. And as I say, they should identify different ways of helping each other as well, and with the problems that are clearly still an issue. I'm pleased that you've set up a monitoring team from your new partnership, and I will look forward, and as all other members will as well, to seeing a report when it does become available. I shall be looking forward to a report from the Safe Now team, along with the ICB, who will be monitoring and measuring safety and improvement. It says in the report that the waiting lists for each adult community mental health teams have been validated, including numbers and duration and waiting for assessment and treatments. I just wondered if you could give us any or disclose any of the information, the results from that, especially the including the patients waiting over 18 weeks. That's for assessment. That's something that needs to be divulged.
Thank you, John. I don't think that's anything really to...
I think it might be the report we gave to the last committee in October rather than the Rampton report.
Yes. I don't think it affects Rampton as much as it does the National Health Service and other patients.
We will be coming back. We're arranging a date to come back and talk about the work that we're doing with our community teams at a future date.
I should say, I look forward to a report from the care group nurses directors. That's a new development, who have been recruited to take a lead on areas of improvement.
Can we have a question, John?
Yes.
Please, instead of just the preamble of the... Thank you.
Well, the question is, the Commission has decided to carry out small inspections, which would create a problem with which would help the departments. But I discovered I just wanted to really know here. Will the problems be discovered early enough if you're doing smaller inspections rather than doing an overall inspection? I just wondered on that question. And finally, the question is, there's been a tremendous amount of work done on at Rampton, so some alarming changes. I just wondered if the governing body at Rampton had been reviewed since the problems have been identified. Thank you.
Thank you. If I just take the first question around CQC. So it's really important that we don't just rely on CQC to give us feedback. So that's why we've really improved our internal governance so that that is really strong and robust. So we have a rapid improvement group where we're looking at quality performance. We have a QPM as well. But if we think about CQC, with their new single framework assessment, actually it feels much better. We have had multiple visits from the CQC over the last year, and where they're looking at just a couple of quality statements based to a Chloe, I think that allows them to be far more responsive, far more proactive, and because they're there all the time, they really understand the context of Rampton as well. So it's been much better as opposed to waiting 18 months, 2 years for a very big full-on visit.
Just to answer your question about the governance, so obviously Rampton is run by Nottinghamshire Healthcare. Nottinghamshire Healthcare has a board. We have 7 executives on that board, and we have 7 at the moment non-executive directors. Actually, a number of our non-executive directors we had one ill health retirement, and we've got a couple more whose term comes to an end. So we've recently been through a recruitment exercise, and there will be 3 new non-executive directors joining the board over the next couple of months. We also have a council of governors, and indeed Councillor Eddy, as you know, is on their council of governors. The council of governors has a number of representatives from around the county and the city, and also representing some of the national services that we deliver, including Rampton. And that council of governors, I mean, there's been no wholesale change in that council of governors, but that council of governors is constantly refreshed because membership, obviously people's term of office comes to an end, and so there is that constant refreshment. Thank you.
Thank you. I think that's all the questions. I'd like to thank Jan and Diane for coming along and explaining the workings of Rampton. I think we're all a little bit more knowledgeable now what happens there and what's going on. And it's interesting to hear now after the problems they are now working with your sister hospitals in a similar situation. You're getting information from them and sharing information, which is very pleasing to hear, which has been happening in the past. And you've also got some staff skills improvement. You're improving on the sign language because you're a specialist deaf hospital, which is really good to hear. Although you didn't say in the report, you still have problems with illness and absentees, so and that's always going to be an ongoing issue for you with staffing problems. But there was also more progress to be made. Reading through this report, it's still a fair way down that road to go. And part of the recommendations we have, which I'm just noting, is that to members to note the progress and improvements being made, but also whether you come back in March and just give us another update of where you are. And I just wonder how often the QC go in and see, or are they constantly there now working together?
Sorry, they're continuously there. Yeah.
Thank you. So once again, thank you for coming in and giving us a presentation. And if you come back in March, I think we'll appreciate that report. Thank you. Members will see the recommendations on page 15. They are to noting. Are they agreed to note them? Thank you very much indeed. Thank you. And thank you again. And members, if you want a 5-minute break, I think we can do now. I will just change personnel for the next ICB part of the meeting.
When I said chaperone patients, I think that were quite
members. Thank you for that. Thank you very much. We are now gone live again. So we move on to item 5, the Nottinghamshire Integrated Care Board Financial Stability Update. And I'd like to welcome Alex Ball, Director of Communications and Engagement, and Victoria McGregor Riley, Director of Strategy Systems Development. I have to say, Alex, that the report really wasn't quite what we really were asking for. We're more looking at what, and that we know you've got financial problems. We were asking what the proposed changes have on residents and patients, that we represent, the people we represent, if there's any changes in services, etc. Whether you can present that in your report as well. We hear on the news where we're going to have the new diagnostic hubs and this, that, and this can help reduce patient numbers, but that's all going to cost money, because we've got to be staffed and equipped and everything else. Have you got the money to do that? Or is, because all we hear from your voice is about savings. And then we hear from the government that it's all about putting more money in and improving things. So if you could expand on that, please, in your report. Thank you.
Yeah, absolutely. Really happy to, and happy New Year, everyone. Good to see you all. So absolutely, we're here at your request to kind of provide an update on our financial efficiency programme. I think it's fair to say, and you've said it as well, there isn't a lot of new news. So we are working through our financial plans for this year and next year. And at the moment, we don't have proposals coming forward that will cause the sort of changes that you've kind of alluded to there, of kind of real patient-facing changes to our services. And that's a good thing, isn't it? And we'll kind of set out for you how we've been able to manage our financial position for this year to avoid those kind of changes very, very deliberately. But I think it's important to say that for next year and subsequently, we probably will have to get into that territory. So whilst we don't have, here's a list of services where we're going to be changing this or changing the other, because we're not at that stage yet, we probably will do in the future. And therefore, that's why we're keen to come to kind of keep the dialogue going and kind of discuss how we might want to share that kind of information when we have it in the future. So if we could just go on to the next slide, I'll just give a quick bit of context and then I'll hand on to Victoria in a moment. So just as a reminder, funding to the NHS in our area is growing year on year. So that's a really important point to remember. Whilst we often talk in terms of slight doom and gloom, there is more money coming into the NHS in Nottingham and Nottinghamshire this year compared to last year. But the costs that we're experiencing and the demands for care are growing and growing faster than that. We have a legal duty to balance our books as well as, provide all the right care for people. And that means we've received additional funding this year of around £100 million to help us balance the books. But we need to find savings this year of around 250 million in order to kind of balance those books. That's about 6% saving. And then for next year, i.e. to the end of March 2026, we have to be in financial balance, as we kind of call it. That means we're going to have to find similar levels of savings next year as we have done this year. And as kind of Victoria and I can kind of hopefully draw out for you, a lot of kind of the perhaps technical changes or things behind the scenes or administrative savings, which we've been able to use this year to deliver our savings, there won't be much more of that available to us next year, and that's probably when we will have to get into some of those more kind of patient-facing changes. So we've shared with you previously some of the proposals we've been considering. Some of those have progressed sort of faster than others this year, but overall, very deliberately, our approach this year has been to minimise any impact on frontline services. But as we move into next year, that kind of balance probably will have to shift. So I'm going to hand over to Victoria now to kind of perhaps give a bit more detail on the position for this year and then how our decision making will progress for next year.
Hi, hopefully everyone can hear me okay. So what we've done is identified or categorised the kind of decisions that we're reviewing. Councillor Adair mentioned earlier about the absolute need for us to make sure that every single penny is spent as wisely as possible, and that is what we're doing with absolute rigour. almost a line by line review. Just about every single penny that we are spending is now being considered as an opportunity. And as you can imagine, as Alex alluded to, that needs some thought, it needs some time, and it needs proper and rigorous processes in place. So the themed approach that we're taking, as we've outlined, is one is around business as usual, as we would call them, efficiencies. So where can we reduce the amount of money and enhance the value that we have of things that are routine corporate ways of working? So, for example, I'm going to just give you a few examples. I'm going to pluck out the air. Are we spending every penny wisely when we are seeking external advice and support from, for example, legal companies? Are we maximising opportunities to learn from other people so that we can reduce costs where otherwise we might have brought in an external consultancy? Those kind of things. Are we using every penny wisely when we're offering advice to our clinicians about the prescribing routes that they take and the medications that they prescribe? So that we would classify those as being business as usual. You would expect every organisation to have a really good sense of their own hygiene when it comes to their financial management. Those are those kind of things. We're also really reviewing every opportunity when a contract comes up for renewal. Is it the right thing to just replace like for like? Is there an opportunity to consolidate how we're contracting? If we've got a similar service and we can't justify why we would have any variation, can we consolidate those contracts so that we can get better value for money and produce the same service for our local population but at a reduced cost? So the quality and content doesn't change, just opportunities to create greater efficiencies. So that consolidation is a really good opportunity for do that. Deferred investments are where we can say, actually, without any significant impact on our patient population and the provision, could we delay the implementation of this? Are we making sure that, for example, where we've had short schemes like pilot schemes to look at the efficacy of whether something works or not, are we really, really taking the time to evaluate and making sure that we are proceeding with any further implementation in a robust way? And can we delay that until a further point in the financial year so that we can reduce the costs incurred in any one year without it having any impact on direct patient care? Another key area that we're being far more rigorous around is the adherence to existing policies and criteria. Where we have really good evidence that something that somebody may want to do clinically is the right thing to do, that's fantastic. But actually, where there isn't that rigour of evidence, or indeed we've got national guidance to suggest that isn't the right thing to do, we need to be really clear that we are providing appropriate care to people. So where we feel that national guidance is not being absolutely rigorously adhered to, where our existing policies indicate that to be the case, we will absolutely contract comply the providers to that. So we've always had a level of rigour, but we kind of really escalated that sense of reviewing every single line to a level of detail that's now needed. Sorry, Councillor, okay. And the other opportunities where we can is bringing in extra resources into our system where we have the opportunity to do so. So there is, for example, an elective recovery fund, which is an initiative that we can, where we've achieved particular elective recovery targets, we can receive money from NHS England to support the local system. So where we can bring extra money in, we're also supporting to do that. So it's about making sure that we are efficiently and effectively using the money we've already got, looking at every single budget line, but also where can we bring in additional income where that's an opportunity. The process that we've implemented is outlined in this slide here, but basically it goes through the idea of having a process that we internally understand and can maintain oversight of. So somebody will come up with an initial idea, there will be a commissioning manager, or it could be a clinician, or it could be a provider. So ideas come from multiple sources about what can we do to use our money much more wisely and effectively. There'll be some initial consideration of that. Is it a really good idea? What would be our concerns, or what are the opportunities? Who are the people that we need to engage as part of that consideration?
And sometimes things may sound really good, but initial exploration, know that that's not something we want to explore. But if it is something that we want to explore, we will then dedicate a range of resources across the organisation, very often working very closely with our wider partnership to explore it. Most of the time, that will also take some requirement about what's the evidence base, what does national policy suggest, what do our partners think, what's happening elsewhere in the country, what can we learn from other areas. So we'll do that desktop review, we gather lots of information and evidence, and then engage much more widely with the relevant stakeholders. We'll develop then a proposal based on the information that we've got and the feedback that we've had. That will go through then into a formal internal governance process for formal consideration. We've got a group that is specifically set up. It is a very wide-ranging multidisciplinary group that will involve people from a contracting expertise, finance expertise, comms and engagement expertise, a whole range of different internal skill sets, experience, and we kind of kick the tires of that idea and make sure that it's gone through that internal rigor. We will then make recommendations into a formal decision-making forum of the ICB, which is our strategic planning and integration committee, and they will make a decision, or if it is a certain level of financial implication, that could go straight through to our exec colleagues and our chief exec to sign off. So the graphic that you've got here on this slide shows you that general process of internal rigor to review the decisions that we're making, so that you can feel assured that all those decisions are subject to a level of scrutiny that you would expect us to have. And as Alex was mentioning before, what we're finding at the moment is most of those things coming through here, through this tender process, are not having a massive, significant, or potential significant impact on patient-directed care. But we think there are things in the pipeline that may do that in the future, but they're still at that stage of the pre-decision making point. So that's the process as outlined in the slide. Alex, do you want to just...
Yeah, I think as I said in the opening part, we're keen, as always, to work with you, work with the committee, and as and when those proposals that Victoria's talked about coming through the pipeline have progressed to the stage where we've got a sort of firm proposal that we'll want to share more widely, then absolutely we'll want to come and talk with you and kind of share that and get your thoughts on it and discuss what that might mean. And we're happy to come to the committee whenever is suitable for you, appropriate for you in your work plan in order to do that. Thank you.
Yeah, thank you, Alex and Victoria, for your presentation. And I'm pleased you're going through the budget line by line, but you've been coming here for a while saying that you're having to make savings. I'm surprised you haven't been doing that before that, to be perfectly honest. Savings have to be made. So, and the amount of savings you have to make, I find it difficult to believe that there's no issues with patient experience and that. With the savings that you make. I can't believe that you can make all these savings without having, an effect on the patients and the treatments that you give. A couple of questions I have first. I know you just faced a large fine for misconduct issues. Does that come out of your budget? You faced a large fine for NHS for misconduct case recently.
Are you referring to the CQC prosecution of Nottingham University Hospitals?
Yeah.
I can't speak for the trust, so we can check that. But
does that come out of your budget, or does it come out their budget, or their budget is your budget?
It's collective NHS money, so yes, I think that will have to be factored into
which is an issue which you have to address. And do you do shared services and contracts with other trusts? Because that's where economies of scale can come in. If you're order larger amounts from one company, you often get better discounts, this, that, and the other. But do you share contracts and services?
What we are encouraging considerably is, as you said, really, it's maintaining a sustainable financial position isn't just a what we're going to do this year thing. It is about how do we work differently into the future and encourage all members of the NHS family to work very, very differently. part of that is very much encouraging our acute trusts and our community providers to work much more closely and in partnership and work collaboratively to achieve better value for money. So yes, absolutely, we are encouraging our acute trust to work together, and indeed they've got formal mechanisms in which they are progressing those considerations as a provider collaborative, but we're also engaging very actively with our community providers, and we will be doing so with our primary care providers to see what opportunities they have for working together that can release greater value in the money that we spend in the NHS locally.
Okay, and do you use the same IT platforms as other trusts?
As was mentioned earlier, historically the NHS has enabled individual trusts and organisations to set up their own IT systems and software responses to their needs. Increasingly, you will be aware that there is currently a national policy direction of travel towards greater digital maturity as part of one of the 3 shifts that you'll be aware of. That's from hospital to home, analogue to digital, and treatment to prevention. As part of that, there'll be a new NHS 10-year plan that's due to come out in the spring at some time. And we have an expectation that the road towards digital maturity will very much spelled out a little bit more there. But locally as well, we're also actively looking at opportunities to consolidate our digital maturity. So, for example, we've now got a shared chief digital officer across both Nottingham and Nottinghamshire ICB and Derby and Derbyshire ICB to think about how we can create those synergies in the way that we mature digital engagement with our local communities. So there is a lot of work happening to support interoperability, record sharing, and better use of clinical and other systems to share data so that we can actively work to target where we put our resources much more effectively. And I think Jan alluded it again to earlier about that sense of personalised care and personalised treatment. We know that there's an opportunity to have a bigger population health impact where we target resources to specific population cohorts and communities, particularly in areas of most deprivation and disadvantage where we know that those needs are probably greatest. So record sharing and greater interoperability will definitely help with that. That is part of what we want to really focus on. Is already part of our integrated care strategy, and it will be moving forward much more of what we want to focus on in the next few years.
Thank you for that. Yeah, because I know IT can be very, very expensive, so it's interesting. You can share and use those facilities. Councillor Lee.
Chairman, thank you. I've got 5 questions. I'm just going to ask them all at once, if that's okay. How will the delaying of investment in 2024-2025 affect services in areas like Newark, and what is being done to stop this from leading to worse patient care? Question 2, with our 68.5 million saving target for 24-25, how will the ICB achieve this without cutting key services or adding strain already stretched staff? Question 3, Newark has already seen service reductions in the past. Can the ICB guarantee that future cost-saving measures won't result in further cuts to local services, especially in rural areas? Question 4, how will the ICB ensure that cost-cutting plans don't prevent people, especially those in disadvantaged areas, like parts of Newark that I represent, from accessing care they need that aren't able to travel to Mansfield? 5, if the 2025 million pound saving target for 25-26 isn't met, what steps will the ICB take to protect vital services and avoid cuts like those seen in Newark? And what plans are you doing if you don't meet the 2025-26 targets? What plans have you got in place?
Thank you, Councillor. I don't know whether you got all that, yeah, but I know the urgent care centre is on the agenda for the next meeting anyway. So yeah, okay, thank you.
Sorry, I'm to lean over the section button. Thanks, Councillor Lee. We haven't, and we don't forecast, and we haven't. And I think we had this question last time we came here about the Newark, and I think we answered that fully last time. There are no plans around any particular disinvestment in Newark. We can't absolutely categorically state that there'll be no reduction in any service, but what we've committed to is, as Alex has already mentioned, if we do feel there's significant reduction or significant impact, we will come back here and keep you all absolutely informed. Just in terms of where we are, where the opportunities to make the greatest savings have been to date, within those themes that I've already spoken about, just to give you an illustration of how we've been able to do this without it directly impacting, one of the things, one of the areas where we've had really good success in this year that has contributed significantly to achieving our savings targets is around continuing healthcare. And what we've done is reviewed those packages of care where patients have been receiving care for a long time that haven't been reviewed as timely as we could have done. And what we've done is invested money to support that absolute alignment with people's needs with the packages of care that they're receiving. So that actually is helping patients, is receiving appropriate care, they continue to receive what they need, but actually it's also saving money as well. But importantly, patient outcomes are actually being improved as a result of it because people are getting the care that they need. So we're also reviewing very rigorously the opportunities to save money around prescribing. So where a drug may be a licensed drug or where the cost of the drug has significantly increased, we're able to advise our local clinicians about alternatives using generic prescribing and or cheaper drugs with exactly the same efficacy of the original drugs. And all those changes are done in consultation and engagement with the patient themselves. So those are really good areas where, because of the rigour we're putting in the process, we're able to save money without it having a negative impact on direct patient care. So that's just to give you another flavour of those key areas that we're working on. You're absolutely right. What we do need to make sure is that we continue to provide always, and that's our commitment as well, to provide the care that's needed, particularly for those at most disadvantaged or those where we can find the opportunity to improve patients' outcomes. And I mentioned earlier about areas where we have significant disadvantage and already people experiencing health inequalities, and as Sarah mentioned earlier, underserved communities that we're aware of, and we're all committed to that agenda. And that's why, again, what we need to be working on, we are starting to engage actively with partners in the development of the integrated care strategy refresh, is the way that we transform our services in the future to build on the partnership working to make sure that we do that. Again, there's a model of working, integrated neighbourhood health and care model that people may be aware of, and we're actively seeking opportunities to develop and mature that approach in Nottingham and Nottinghamshire. And that's where we can build on the really fantastic work that's happening in our place-based partnerships and really build community-focused ways of working, bringing together health and care teams, making sure that we've got access to specialist advice when we need it, but really supporting the care of people within the communities, so that we can make sure care is closer to home, but we also improve outcomes. So you're absolutely right, Councillor Lee. It's a real opportunity to do that, and we are as committed as you are to make sure that those most disadvantaged continue to receive the care that they need.
Just as a follow-up, Chairman, you've been tasked with doing a 225 million saving. How much actually has the NI contributions and minimum wage increased to your bill? Because from the maths that I've done and from how much I know it costs this council, is actually, if it wasn't for the NI and minimum wage increases, the £225 million would already be gone.
I can't give you, I don't have the specific detail around that, but obviously it's had an impact. However, again, in terms of the overall financial impact on us, we obviously have money from NHS England that will support some of that. So we can give you that more detail outside the meeting, but I don't have that information available now.
If you could bring it to the next meeting, Chairman.
Yes, thank you. I believe it doesn't come into fruition until April, but I'm sure you have to budget for it. But normally you get reimbursed, but I don't think you get reimbursed as much as what you normally do. so it will have an effect on your budget. Yeah. Councillor Bailey.
Thank you very much, Chairman. I've just refreshed my memory by looking at the July 24 proposals. There were quite a lot. I suppose what I was wondering was, what we hoped at this meeting was any of those proposals that you did have, could have, maybe if they were firmed up, we could possibly have a report that, you know, shows some of the impacts of these savings. I mean, I'm looking at a few examples. I've talked about reshaping Bastille's hospice provision. We talked about that in July. We still don't know what's happening with respect to that. So, are any of those proposals from July, have you firmed up on any of those? Or are they all firmed up and you're all going ahead with all of them? Or are there any of those which you were looking at in July, you've decided, actually, we're not going to do that? Because I know a lot of those proposals were background, getting cheaper medicine and whatnot, that didn't require an update because they were quite self-evident. I am aware there were a few issues, for example, transport, that would have impacted patients that, you know, I think people would be quite interested to hear where you're going with that. As I think almost alluded to, you've got a 10-year NHS plan where, you know, we've got neighbourhood NHSs that may be coming in. It's all a bit up in the air for you guys, so I suspect it's almost a holding budget until you get the long-term plan from the government where you can actually look at what you're going to be doing for the next 10 years. So, any firm proposals from July 2024 that you've?
So, just in terms of the Bastille Hospice, for example, we are actively engaging with Notts Healthcare Trust and the trustees to obviously maintain the hospice provision, but also support the care close at home as well for people. So again, the outcome of that has not gone through a formal decision-making process yet. It's still in that middle stage of working through with stakeholders exactly what it is we want to do. But my personal understanding at the moment is that won't significantly impact on patients. So that's what I'm saying. What we're trying to do is really work effectively with our partners without changing significantly the impact on local patients. But where we do feel that that's going to be the case, we will bring it and have that conversation with you. But as I said, a lot of the progress we've made is through that internal business as usual, the consolidation of contracts. So those things are not impacting on the front line in the way that we may have anticipated very, very early in the year, that some of the stuff that we will do. But we do have that commitment to come back, and we can provide you with a bit more granular detail where you specifically requested that.
Just quickly come back, Chair. So when does this final decision have to be made then, for the budgets then?
What we're trying to do is make sure there's rigour in the process, and we're trying to achieve as much savings as Ike's already mentioned within this financial year as we can to support the 100 million. But this will be ongoing. Yeah. So this isn't just for Christmas review of how we're working. Yeah. So there is the here and now this year, what can we achieve and maximise the opportunity. But we're already starting to think about and what are we going to do for next year as well to make sure that there is recurrent savings opportunities. But that's why I'm also mentioning the fact that it's not just about a line by line review of what we currently do. The whole system needs to be transformative in the way that we work and engage with each other.
Yeah, I suppose people watching this would look at it and go, okay, you had these proposals in July, we're 6 months on now, you've still not firmed up the proposals, we're looking at budgets in April. Is it going to be a quick sign off in March that no one really knows about? And, you know, where you already have an idea in January, because you will have an idea of what you're proceeding with and what you're not proceeding with. And, you know, people will be listening going, have they made their minds up? Or are they all telling us they haven't made their minds up, but in 2 months' time, they will have made their minds up? I suppose that's, for those outside the meeting, they'll be looking at that going, is this going to be a stitch-up? So I suppose your assurance is that, you know, if the decision's not made in March, it'll be made later on in the year, although the aim's March. If you're not fully appreciate or you're not completely sure about it because of feedback, you're not going to go with March, that's what you'll do. You'll stretch it into the next financial year. Yeah. Is that an assurance you're willing to provide?
Yeah, absolutely. This is an ongoing process. It's not a guillotine at the end of this period. That's it. All the decisions that have been made. Absolutely not. What we are focusing on is making sure that we have a rigorous process in place and that we do it properly as a process of appropriate involvement and engagement as we go along that process. and what will materialise, and we have made that commitment that we will come back if there are those changes where we feel there's a significant impact on local patient care.
Thank you, Chair. I suspect your greatest cost is staff. And I suspect there must be savings within there. So what sort of explorations do you have for, let's say, early retirement packages, redundancies, etc.? It's a difficult subject, we all know that, but it is your greatest cost.
Yeah. So we've got the kind of two elements to that. Obviously, we've got savings that we're trying to work through as a system, because there's a system financial balance that we're trying to achieve. And as part of that, we are having ongoing conversations with our provider colleagues, who obviously employ the vast majority of staff that are in the NHS family, particularly in our acute sector, about their staffing costs. That's including things like agency costs, so trying to reduce that wherever we possibly can. Having conversations about, have we got the right skill mix in place? So, you know, do we have to have people at a higher skill mix? Can we probably change that to create efficiencies wherever possible? Is our overall headcount the right headcount? We're working really hard and producing. Our chief people officers across the system work very much now hand in glove to try and reduce and mitigate the costs associated with workforce. So we're doing an awful lot of work in that space to try and reduce those costs wherever possible. From an ICB point of view, you'll also be aware that we've already been working on a 30% management cost reduction over the 2-year period of last year and into this new financial year. And that continues to be implemented as well. So you're absolutely right, staffing costs is an area of keen interest that we're trying to reduce.
And a challenge.
And a challenge, absolutely.
It's very difficult when you're working with staff. Very difficult. Thank you. Yeah.
Just as a rise to that, what percentage of agency staff do you have to use? Or now, what vacancies have you available? Because obviously you're filling vacancies with an agency staff, so what's the percentage?
I don't have that level of detail to hand, but I'm very happy to supply it outside the meeting.
It's diminished.
Insurance,
yeah,
It's diminished greatly.
We've diminished it hugely over the kind of recent months for exactly the reasons you've described, to move effectively that work from kind of quite costly, agency staff who might not have familiarity with working with the systems and working with other colleagues into, mainstream employment. That's better for everyone, isn't it? So our agency numbers now are extremely low, kind of diminishingly small. There's more to do on what we call bank, which is kind of flexible shifts for individuals. And whilst, again, we want to maintain that ability and that flexibility to make sure we've got the right clinical colleagues serving the patients, again, if there's ways to do that through substantive kind of employed posts, then that, again, is better for everyone. I think the important point to note, though, is that our workforce collectively across the NHS has grown considerably over the last few years. And that's a good thing for employment, and we kind of take our role as a big employer really seriously. But actually the real opportunity over the next 2-3 years, which Victoria's doing an awful lot of work on, is how we can use that workforce differently, work with them differently, take out duplication, find ways for really expert clinicians who do brilliant work in our hospitals to actually do more work out in community centres and GP practices, taking care, as the kind of rhetoric goes, taking care close to people's home. That shift will involve people working differently as well. So in some ways, Councillor Turner, to your question of, do we want to be looking at early retirement or voluntary redundancy? Not really, if we're honest. It's more about using what we've got really effectively and getting the most from that, rather than just thinking about how we can reduce it. It kind of achieves the same thing, doesn't it? It produces more care for people in a more flexible way for the same or less money, but it's not about taking roles out as such.
Thank you, Alex. Councillor Dare.
Thanks, Chairman. I'm a little bit perplexed. In one statement here I read, savings target is 257 million, efficiency target 68.5 million. We've got another 100 million coming in from outside, and then we're challenged with a 6% reduction. So I'm not too sure how you mix that bag up and get a result. Do you have a baseline budget? Obviously not, from what you've just said. Do you know the cost of what I would call employees overall? Do you know the cost of procurement overall? And then do you know the cost of your asset management and overheads and all the rest of it? And once you get into those figures, then where can you really make some savings and come back and say, yes, I can make my 100 million or my 257 million from these particular areas? And how then are we going to reinvest that? Are we going to, how do we get best value? And where do you do your benchmarking to know that you are getting best value? Because that's an important factor. Do you do that with other trusts, or who do you go to? Because those are important factors of where the finance comes. And I mean, you're dealing with such large sums of billions that, 1% on a billion is a lot of money. 0.5% of a billion is a lot of money, but 6% is also a lot of money. So how do you comprehend bringing this together into a proper baseline budget plan, and who then makes the decisions on that? Because you get the feeling that what might happen in the trust in Nottingham is guided by what comes out of Treasury in Westminster, that you're not totally in control of what you're doing yourselves anyhow. So how does that mix all work? And I find it very complex as to how to get a grip of it, to understand. And who has to administer it? Can you, or is it an impossible task?
That's if you can.
I'm going to have a go answering this, but probably not to do it justice. So I'm not a finance lead, but I'll have a go. We have an annual allocation from NHS England. Our allocations are going to be shortly announced, and that will allow us to forecast what our position will be with a lot more detail, but we generally do understand what we have is a system approach. So our finance leads are very, very kind of good at understanding absolutely what you said, their baseline budget and how the money is currently spent. We have a really robust oversight group that is established where all finance colleagues come together and they routinely review progress against that expenditure. We can provide you with a range of detail in all those areas that you've said. I'm not sure that was the focus of what we came here today to do, but we can provide that information at a future meeting if that'd be helpful. But yes, it is always hard, isn't it, to do everything that everybody would want to do with every piece of information resource that we have available to us. We have a really good process of understanding our existing budget allocations and how we're spending it and where the opportunities for savings and greater efficiencies are. That's the process of the review that we go through when we try to find those opportunities to make further savings. Is that a process that gives us opportunities for longer term investment and opportunities and understanding? We're hopeful that some of that longer term view will come from a 10-year plan in terms of expectations. But yeah, that's the way that we currently manage our financial resources as a system. And obviously we have oversight on that by NHS England as well.
I can just quickly try and unpack some of the numbers, Councillor Adair, but you're right, it's complex. It's really complex.
To ask is, who is responsible locally? Is it the NHS Trust, the Chief Executive, the Chief Financial Officer and his team? Or is it more complex than that they don't have that accountability in total and they are guided or told what to do from elsewhere?
Each individual trust has its own responsibility, statutory responsibility around its financial balance. The ICB has statutory responsibility for financial balance of the system. Yes.
Want to come back a bit more?
Yeah, no, I can try and step through the numbers. So collectively for the NHS in Nottingham and Nottinghamshire, when we looked at our budgets that we've been allocated for this year and what we think the demand was going to be and all the other kind of costs, it looked like we would be overspending by about £100 million versus the money that we've been allocated. So overspending on our budget. We've been able to agree with NHS England that we would be given that extra money, but as part of that, we would need to make savings of £257 million, and the ICB's share of that 257 is the 68. So hopefully that, and the 6% is the same as the 257. They're just representing the number in a different way. But yeah, it's complex. But we'll try always, if we can, to unpack it and explain it. But yeah, it is complicated. But it probably should be, because overall the NHS is, it's a third of government expenditure. It's close to £200 billion a year. It's a lot of money, so it is going to be complex.
Just one further question, Chairman. Would you have a balance sheet that could show all that of how you do it, or not?
So we publish our accounts as the ICB. Each individual NHS provider will publish their accounts absolutely as part of our annual reporting process.
Thank you, Councillor. Thank you. Councillor Reddy.
Thank you, Chairman. I think I've said this before. I totally agree with making efficiencies when it comes to things like drugs and things like that. But I really, really want to make sure that prevention is part of that. A really strong message on prevention. I've just had a look at the Reforming Elective paper that's just come out. I don't know if you've seen it. It's come out in the last couple of days. And my worry is that you're saying you've got to cut budget by March 26, but also by March 26, the new government want you to, by March 26, government wants 65% of patients waiting less than 18 weeks. They also want a 5% improvement by March 26. How realistically can we make sure we're balancing the budgets when there are quite big figures in here where you'll have to try and balance books as well as bring more cost in to reach those targets? And there's just other little bits that I've just picked up, like by March 25, so that's literally 3 months' time, a clear vision for how health inequalities will be reduced as part of the elective care reform. There's a lot of work to be doing as well, and I just worry that will impact on the budget of Nottinghamshire as well.
So yeah, it's a challenge, but actually we're all making really good progress against some of those targets. And again, we can come back and give you more information about that specifically. You're absolutely right. Focus on prevention. I mentioned those 3 shifts earlier. It is absolutely critical that we support not just the really expensive treatment of people who are already there needing that treatment, but actually we try and prevent as much of that demand as we can coming through the system. We know that we've got a really high proportion of growingly elderly population that are going to need much more complex support as we move forward. We're doing brilliantly well around cancer survivorship, fantastic. So we've got more people living well, which is fantastic. We want to keep it that way, but we want people to live a healthier later life. So prevention is going to be critical, and it goes back to the argument I've already made about it's not just the here and now transactional. We need to do the transformational change working as partners, and that will also involve working very closely with the health and wellbeing boards, for example, our public health colleagues as well, to do that. And the integrated neighbourhood health and care team model is very much about that prevention agenda as much as it is about treatment. So we're making really good progress already against some of those key targets. Yes, it will continue to be a challenge, but the point that we've made earlier is that we feel there's an opportunity to reduce the wastage and the duplication that's in the system. So where we've got the opportunity, could we, for example, support smoking cessation as a prevention agenda, not just on somebody who's happened to have an opportunistic conversation, who's paid to have a conversation about smoking cessation, but actually could our community pharmacists do more on that? Could our dentists do more on that agenda? Could our district nurses have a conversation or introduce a conversation around that? how do we really proactively identify those people who are at most risk of using hospital services? How do we reduce the amount of exacerbations or the frequency of attendances? So we can achieve those targets if we eliminate the waste and the duplication that has inevitably creeped into the way that we do things. So those are the opportunities that we're really focusing on. So overall, patients still get the care that they need, but what we do is take out that opportunity to do the stuff that's not adding value where we possibly can. That's the real golden thing we're trying to find. Does that make sense? Hopefully.
Thank you. Yes, and I think I'm a good example of how well cancer treatment is working from NHS. Thank you for that. Yes, Councillor Wilmot.
Yes, thank you, Chairman. Firstly, a very interesting report, to say the least. The serious issue is that NHS doesn't have enough resources to do the job properly, and until this issue is addressed, I'm afraid there'll always be a problem. It seems to be a clear lack of confidence that the government will give the ICB the investment they need. This is covered in 3C of the report and states national guidance has not yet been issued for 25-26. However, early plans indicate NHS partners in Nottingham and Nottinghamshire will have a £250 million savings requirement. How can that be when you actually overspent by 100 million? I mean, surely that 250 million should be spent on patient care, whether it be expensive equipment, extra staff, or other expenses to improve the services. I don't see the logic I see the logic of trying to cut down on expenses, but to make an initial savings, there is no savings really, because that's got to be spent. Yeah. Questions coming. Yeah. It says in the report your objective is to minimise the need of frontline changes in the service and to maximise efficiency, productivity, strong financial government. I would have thought deferring some investment in services may cost lives. If perhaps you could just iterate on that. I've always been very popular on early intervention schemes so that the health problems don't occur in the first place. Investing resources into early detection schemes would save untold millions of pounds in the NHS, and yet you have it down as a possible deferred investment. Can you explain this to me? I do feel that the administration costs will have to be looked into. There seems to be a meeting after meeting taking place with not a lot of substance, and when it should be the patients that should be the priority. Now, prescribing is also a problem. How many companies are overcharging with their medicines at the moment? I mean, that's absolutely incredible. There should be a cap on medicine profit margins. I just wondered if you've lobbied the government on this issue. And can I just say that the whole situation is very, very serious at this present time. But making savings, it's a nice thought, but the patient should be the priority. Thank you.
So, I mean, Councillor, it should go without saying, but I do want to reiterate our absolute and overriding focus is for our citizens, for our patients, for our residents, whatever we want to call them, making sure that the 1.2 million people who we serve are at the centre of our thinking, and that is absolutely always our approach. And again, that's why we've been able to, and believe we will be able to deliver this year's savings without any impact on those frontline services. Next year is going to be a challenge, as Victoria has acknowledged, and as I will acknowledge. There is a high level of expectation from the government. We don't quite know exactly how that's going to play through. NHS England, probably within the next week or so, will be sharing with us, here's the new kind of priorities from government. I think the expectation and the hope is that will be accompanied by, therefore you could deprioritise these things, because there's always choices in any strategy, aren't there? But overriding that, or not overriding that, alongside all of that, we have a duty to balance the books and make sure we're getting absolute value for money from every single pound that we spend. So we have to do it all. It's not an either or. It's not a can you hit this target or can you make these savings. We have to do it all, and that's our intention, and we believe we will be able to do that for next year.
Just in terms of the prescribing, obviously, it's not my area of expertise, but actually we are subject to national, international pricing mechanisms around drugs, and we therefore monitor them actively to make sure that we are offering our clinicians the choices and making sure that they're aware of the cost of those drugs. But we, as an individual ICB, that's not something that we can affect the market on as much as I'm sure that we'd like to on some occasions.
Yes, thank you. I'm afraid the drug market is a commercial market, and they probably have to reinvest anyway to finding even better drugs going forward, which costs a lot of money. Yeah, those companies.
Didn't answer the early intervention schemes. I just wanted an answer. Does the, as I say, it's down as a possible deferred investment. That's early intervention schemes or investing resources into early detection schemes. It's in the deferred investment. I wonder if they could explain the reason for that.
Yeah, so the SDF, I think that's what you're alluding to, Councillor Wilmot, it's mentioned in the paper, is a non-recurrent scheme. So it's non-recurrent money that the organisation has to support mainly transformational initiatives. Therefore, there's no recurrent commitment to that money. So what we do is we identify opportunities, but because it's non-recurrent and therefore is not routinely relied on, we make a decision about the efficacy, the best use of that money at any one time. That's why we can defer to say, actually, that may be a scheme we want to support, but we're not going to do it right now. But that's not a business as usual scheme. That's not something that's routinely commissioned. It's additional money. It's above and beyond. And that's why we can make the decision to defer.
Question, John. Any other questions? Sarah.
Yeah, thanks. I suppose where I'm sitting at the minute, I'm hearing you hopefully will balance the budget at the end of March. There won't be any impact on patient experience, that services will continue. From a patient perspective, there'll be work going on behind the scenes. I guess for me, when the ICSs and the ICB came into being, it was to create much more integration across health and social care. It was to bring the system together in a way that it hadn't been done before. And I guess a lot of us in this room have been working to that aim and put a lot behind that. So I guess what I suppose I would hope to see in Scrutiny is that report that I think probably we were expecting, which is where have those shifts created efficiency? Where have there's the work that's going on, identified the areas that have already started to reap rewards in terms of the way that the system works differently in order that patient experience is improved, that you can start to meet targets and all the things that you need to do because you're working better as a system. Because that should be in play, and I know we're in the middle of starting to refresh the strategy and review the strategy, for me there's something about already knowing where the services that are at risk are, where the services that you see may need to change, and I'm not having a judgment on whether I think when we talk about cuts, people think if you take something away, you might not be replacing it. It's whether you're taking something away in the form it is and creating something different that delivers the service patient needs, but in a different way. And I think that's what I think the public and patients need to understand is where have things been taken away and nothing is replacing them, or where things have been taken away or reduced, but other ways of working replace the service in a different form. You know, we've heard this around, you know, Newark you mentioned, Councillor mentioned around the issues up there. Things have shifted in the way services are delivered and moving towards urgent care, for instance, instead of emergency care. These are shifts that have got a lot of work behind them. I think coming forward, would want to see that there is already a knowledge of where you might be making those difficult decisions. Because we're in January, you'll be starting to make them and think about them starting in April. It's only 3 months away. So we should know where they are. We should know where those touch points are. So my question is, how are you working with the system? Not you as commissioners, but the providers, because we've seen this in local authorities where big things have to be cut. And I know this local authority might face some of that. We know we've had it in the city. But talking to the system to understand how you might offset some of that challenge by working differently together. I want to understand how that's already happening, and if it's not happening, why is it not happening, and if it's happening, where is it happening? Thank you.
Sorry, I'm already live. Okay, so you're right. So things may not necessarily always change for the patient facing experience, but actually the way that we work together to achieve that may have changed. So we've done an awful lot of work through place-based partnerships. We're doing a lot of work with bringing the community providers together about how can they work together much more cooperatively, consolidate their opportunities. We're talking routinely now on a weekly basis. Our acutes come together with the ICB to think about the overall financial savings, what the opportunities are. So that's where a lot of conversations around the workforce and the bank and the agency type of reductions come through. We also have, through our process, I've mentioned the CRG process, the diagram that you've seen, that is about where people routinely now come together in a way that I think as a system probably wasn't experiencing even 12 months ago. So those conversations happen more routinely now in a way that we form really, I think, constructive partnership relationships. And I think part of moving forward the transformation agenda is where can we accelerate that? There are kind of 3 themes of accelerated ways of working that we want to explore as part of the integrated care strategy. First one is around how do providers work together more? So what can, for example, shared forest hospitals do with NUH around things like fragile services where we've got them? So, for example, an area like ENT might be something, what can we do about sharing our skill sets across our workforce? That's just an example. So we've also got, as a second theme, how do we support our staff operation on the ground to work better together? So how can we start to create those truly integrated health and care teams and build in, for example, a routine way for GP practices to seek advice and support from the specialist skills, and as Alex mentioned earlier, specialist skills coming into the community setting more. That will really accelerate that joint approach and joint working. We've started to do some of this, and direct access diagnostic will help with some of that and consolidate it. We've already created our 2-hour response services. We've created a lot of the urgent response services that are part of that consolidated partnership working. And then the third element is about how do we, as strategic commissioners in the system, work much more cooperatively and collaboratively. So, for example, how do we collaborate more around the use of the Better Care Fund, our commissioning pound, so that we commission services together in a way that is much more joined up. So those are going to be the key kind of 3 themes that we'll want to work forward. So I think as we work into that and get an implementation plan around the integrated care strategy, we'll start to be able to evidence that a lot more. The other thing that's happened, again, which illustrates the way that we work differently, is we've now got system transformation programs established within the last few months. And those are in areas, for example, workforce is one of them, digital and IT is another one, best value is another area, frailty and the transformational change within our community are other areas that we are working in a much more joined up way. And so that will help escalate the delivery of those 3 things that I've just mentioned. So I haven't come in with it, I can show you that diagrammatically, but yes, the whole tone and the whole ethos of the way that we work has definitely shifted over the last 12 months. And I think the opportunity that we've got with the 10-year plan due to come out with the new operational guidance and our refresh of both the joint forward plan and the integrated care strategy will really accelerate that over the next 12 months and beyond.
Can I ask then, do you think it's enough? Because in terms of the big conversations you're going to have next year, the speed of which we've been moving the needle, if you like, into more collaborative, more efficient ways of working, is it enough? I mean, are we operating as a system at the right pace, or is there still barriers in the system that need to be overcome? Because I guess that's the bit we're not hearing as a group. What the the tangible impact of all that work you're describing is having on the system from a financial point of view. The other area from my perspective of Healthwatch is what impact it's having on patient experience. Obviously, I'm going to be interested in that. But I think when we know we've got such gigantic numbers that we're playing with, how much, do you feel that the system is shifting into that right way of working? I mean, I hear that you're saying it's happening, but we've had the strategy for over a year, but we're only starting things now. So I'm concerned at the pace, if I'm honest.
I can understand that absolutely. And what I will say is that it's not just the energy from the ICB that's going to create that, and pace is absolutely critical. With the level of the financial challenge that we've got, this year, next year, and beyond, the pace is something that we've all got a responsibility to help and support. Every single person in this room and outside this room collectively will have a responsibility. And that's why Partners coming together, culturally, this will be a different way of working. And we've all got to put our shoulders to the wheel on that, which I'm hoping from a county council point of view, we definitely will have that support to do that. But I'm really, really clear that yes, we are seeing a change, but yes, there is a necessary level of pace to this change that we need to get behind, and it won't be any one partner that can make this happen.
Yeah, I think that's the key point. I think you're saying this, Sarah, but just to emphasise again, this isn't a choice between can we make financial savings or can we transform services. We will achieve one by doing the other, and we've got to do all of those things. We've got to carry on doing the kind of business as usual background efficiencies. We've got to carry on transforming the way that staff work in different ways. We've got to find the savings on the IT platforms. We've got to re-provide services in different ways. We've got to do all of that to the maximum amount to kind of get us to where we need to. So again, it's not a either or a trade-off. It's how do we do all of those things in concert? Certainly from my kind of perspective, kind of seeing the way that those plans and teams are starting to come together, I think we've got the best possible platform to do that for the coming year, and we're going to have to, because that's the expectation of our population, isn't it?
Okay, thank you. I don't think there's any further questions, so we'll have to thank Alex and Victoria for coming along. Next, talking to us and giving this presentation to the committee. I know it's very difficult to, you're expected to make savings, but also provide better services as well for a transition period as well. You've ever got inflation on drug prices, and there's a change in services as well going forward, and more technology coming forward as well onto the service. So I know it's not easy. But members, when you come back next time, we'd really like to know sort of what, in a more specific way, what the savings are and what effect it does have on patients. If you could probably think about that next time you come, please. I know it's difficult because it's very difficult to say or predict, but that's what we're here. We're here to sort of scrutinise for the people that we represent. Is that's possible, please? But thank you for coming.
We can absolutely do that. So we are completely committed to sharing the information that's relevant on that. I guess the bit we just need to do is have a conversation about the right timings for that, to make sure that we're not trying to produce information which isn't quite ready yet, and you're not feeling disappointed that we haven't brought the right information at the right time. So if we could just offline through our regular conversations agree the right timings for that, then we can absolutely satisfy that.
Okay, lovely. Thank you very much indeed. Thank you. As the recommendations are on page 25, they are for noting. Do we agree we note them? All in favour? Thank you very much. Right, we're now going to move on to the work programme. Move to the end of the meeting. Just a change of dates for you. The next meeting is now being rearranged from Tuesday 11th to February to Wednesday the 12th of February. That's okay. And members will also be notified that the March meeting will now be held on the 18th of March due to the election period. Callum?
Thanks very much, Chair. Just a few things to note on the work programme. I believe in the agenda pack today it was talking about mental health services in Bassett Law. I know that was a long-standing item on the work programme. I believe originally that was referring to the mental health ward being moved from Bassett Law Hospital to Mansfield, essentially. So I think that's what the item was originally going to be about, and that's what we wanted to talk about. I don't know if that's going to be in the future for a different chair of the Health Scrutiny Committee to look at again, but I just want to highlight that's not what originally the mental health service ambassador was talking about. Other thing as well is I know we've got a next meeting after the election is the 1st of July 2025. I was wondering if it would be suitable for a meeting to be scheduled in June 2025. So I know in 4 years ago, our first Health Scrutiny meeting of 2021 of the new term was in June 21. So I'm just conscious that because it's going to be a long delay between March and July, if there could be a sooner meeting after the election, that would be ideal for new incoming members. Final item is one to highlight for yourselves and for you to discuss with other people is the fertility service. I know it's now scheduled for July. The fertility policy review is now scheduled for July. The consultation is ending in a couple of days for it. I don't know when the ICB are going to make their decision on the fertility service. I can't imagine they'll be waiting that long. So could have an assurance that if they are making a decision before July, if it could be moved forward to a meeting where we can shape the discussion. Obviously, if it's in June, it's in Purley, you can't do anything about it. But if it is before then, if we could move the item up to a meeting before then, I think that would be ideal because then we can shape the policy rather than hearing about it 3 months after. Thank you very much.
That's a good point, Callum. The consultation's on at the moment, isn't it?
Yeah, I think it ends on the 10th of January.
So we'll look into that and see what their conclusions are, or whether they are going to release their report on it. Yes, thank you for that, Bethan.
Just to say that school readiness, we finished the task and finish groups in November, and we're going to bring a report to Health Scrutiny, but it's not on there as of yet. I just wondered if we could have it on before the elections in May.
Okay, yeah, it won't take forever, will it? So very small report. Yeah, I'm sure we can put that on better now. That written down, yeah. John.
Thank you, Chair. You heard that we heard today about a lack of investment in the NHS by successive governments. I would remind members that it is exactly now a year since this committee agreed to put health and wellbeing provision in Hucknall. The Pors Cavill Centre, which is the Cavill Centre, in Hucknall. Can I say I feel like a stuck record really, but ask again as a committee, we could put pressure on the NHS and the government to get on with building these primary care centres, both in Hucknall and 5 other towns in England. We feel let down, we really do. And just asking the chairman if he would agree to write to the health secretary, West Streeting, to ask why the delay is, because it's now getting serious. The time's just evaporating, and there's six now, as I say, Cavill centres in the whole of Britain. The problem is they were actually passed by the government, but it suddenly paused and we've heard nothing at all. I wonder if you'd just help us a little bit by putting a letter through to the, as I say, the health secretary.
I will look into that, Councillor Walmart, and see what's what. But I mean, yesterday the government's announcement was that they were going to bring forward these diagnostic centres and improve them. But again, it's all about finance and money, and what money is the government's going to put extra money into to build them and finance them and equip them. But the government has probably supported 22 billion into the NHS this year, so we will see what comes from that. But we'll see where it's spent. Okay. I mean, I for one would like to have the CQC in here for scrutiny as well, because we've had 2 incidents in this county recently, maternity and Rampton, but they weren't picked up until it was really too late. And I just wonder what the realm of the QC is as a watchdog organisation on the health service. How often do they go into places, or are they just reactive and not proactive? So that's something I'd like to have. It probably won't be this year, for the next administration, but I will just bear that in for feed that point into members' minds. Actually, it'd be interesting to have a word with them. If there's no other business, I assume Councillor Henshaw just came for warm this morning. Anyway, thank you, members, for your attendance. It's been a very good meeting, and wish you and the 11th of February. Thank you.